Welcome to Kids Matter. I'm Dr. Elisa Minkin. As a pediatrician, mom, and grandma, I understand how challenging it can be to help our kids grow into their best selves. We are so much more powerful together. Here, I will be sharing the knowledge and wisdom of a wide range of people who understand and care deeply about children. I'm hoping for your input as well, because kids really do matter. They are our future. Dr. Navidi is a licensed clinical psychologist and one of the founders of GI Psychology, a national telehealth practice specializing in helping patients with GI disorders and chronic pain. Dr. Navidi oversees training and outreach at the practice. Dr. Navidi has given talks about GI disorders and chronic pain to organizations around the country, such as American College of Gastroenterology, UNC School of Medicine, George Mason University, Georgetown University, Grand Rounds, INOVA, various podcasts, television, and various state academies of nutrition and dietetics. So thank you so much for doing this with me today.
Oh, it's my pleasure. I'm glad to be here.
It's a really important topic, and I've been listening to you on other podcasts, and I heard something great that you said on the Peds Doc Talk podcast. So I thought that was the best explanation I've ever heard of the gut-brain connection. So I'd like you to start with that, please.
Oh, yeah. So, and I think this is basically an explanation that I've developed over the years for patients and for their parents. I feel like a lot of times people get way too excited about the science. They go into neurotransmitters and hormones and vagal nerve and like all this is great. And we know the science is really solid. But I think what people really just need to understand is we have a big brain, our central nervous system, and we have a little brain, and that's our enteric nervous system. And the two are talking to each other all the time. And what happens in one can affect the other, and what's happening in the other can affect the one. So what happens in our gut, in our enteric nervous system, can definitely affect our brain. And what's happening in our brain can really affect our gut. And once patients understand that this isn't people just making stuff up or it's all in their head, because it's literally not all in their head, because the brain is connected to the body and has a very special connection with that little brain down there in our gut. And so once they can get that foundation, then the rest of it comes easier. Then they begin to understand, okay, why has my kid been throwing up every day for the last, week, but they can't find anything wrong? Why do they have intense stomach pain to the point they're taking them to the ER? But again, they can't find anything wrong. It's not because it's all in their head. It's just because the head and the gut are intimately connected. And so they're always affecting each other.
That's a great explanation, and I want to go from there into what we're now calling disorders of gut-brain interaction. I love all this new information because I'm really tired of this misconception that, like you said, it's all in your head. That's the title now. It's not just all in your head of this talk.
Yeah.
So I want to talk about when it becomes a disorder, because obviously you could say have an upset stomach when you're nervous about speaking. That's not a disorder. That is an example of the gut-brain interaction, right?
Yeah. It's a great example. It's not a disorder. There's, I think, 20 something different disorders classified under disorders of gut-brain interaction. In fact, that term is relatively new, at least from my perspective. I've been doing this work for a while, and I remember when they changed it, I think it was 2017, something like that. And it used to just be functional GI disorders, which is fine, but it doesn't really give people much information. Like, okay, functional. The average person hearing that name doesn't know what to make of it. but disorders of gut-brain interaction, it literally has the key phrase in the title. So it saves a lot of time because people immediately begin thinking of the brain in the conversation. Because the biggest mistake I think a lot of these patients and parents can make is to try to leave the brain out of the conversation. Because when you do that, what you get is years of bouncing around the medical system, looking for answers, looking for another test, another scope. And they just are just reinforcing the problem.
We have to get into that in more depth later, but as a pediatrician, we see so many, and it's not just, by the way, the gut-brain disorders, it's a lot of other disorders that are called functional. And I think they keep changing the name to try to get rid of the stigma of
Right.
it's not real, but still people and physicians often feel it's not real unless I can measure it. And that's
Right.
ridiculous.
Right. And the problem isn't measurement. The problem is our level of scientific sophistication. There's absolutely measurable things happening, the way the nervous system is interacting, that we just don't have the technology to directly measure. So all those people that are stuck on measurement, they're kind of pushing forward this idea that, again, it's not, that it's all in your head, which, is kind of the theme of this episode, right?
Absolutely. Let's go talk more about this, because I think that both healthcare professionals and parents and patients need to know so much more about this. So let's talk more about the most common disorders that we see in children that are gut-brain interaction disorders. I'm thinking, just to give you a push, I'm thinking functional abdominal
Yes.
pain and irritable bowel syndrome.
Yeah. In my experience, I think the most common I would see is functional abdominal pain, and then irritable bowel syndrome is up there too. The good news is, from my perspective, it's very treatable. I remember when I started doing this kind of work, and I was kind of the last call on, the last station on the stop. Usually patients only saw me after they had been through everything and everyone else. And that would be years, and it didn't actually take that long to treat them. And with kids, the treatment is even shorter than adults. So often we'd be getting results in kind of like 4 to 8 sessions. Adults, I'd say on average.
Wow.
Yeah. Adults maybe are more like 8 to 12 or 13 sessions. But kids, they would generally respond pretty quickly. And these are very disabling conditions. They'd have this chronic pain. It would be worse when they would be stressed, but it wouldn't only be caused by stress. Often they would worry that something had been missed and that there was some medical condition that was dangerous to them, and that would kind of perpetuate the problem. But again, these are very treatable problems with the right techniques.
Right. And I'm going to bring up Dr. Beatty Benvogel, who I interviewed for a different podcast. I'm going to link it to the show notes, because she said something that really struck me. She said that it's really important to set the expectations right up front. She compared it to the golden hour that you have in the emergency room, where you have to get that diagnosis of stroke or whatever right away. So that I'm going to link that to the show notes, but the point is that it's not a diagnosis of exclusion, right?
Yeah. I think it used to be considered, but as I understand it, among, let's say, pediatric gastroenterologists, the movement has been that they can get these diagnoses from a good history, and then, depending on the situation, certain key tests. But often I think they're not needing to scope or do other things much more that are much more invasive.
Back to what you said about part of the pain can come from the anxiety that something is wrong,
Yes.
right?
If you wanted to make a theme about these problems, I think the theme would be safety. So a lot of the work is reestablishing safety. The brain, and this is conscious and unconscious level. This, what do I mean? When the brain feels something is unsafe, like imagine, you're walking outside on a lovely evening, you're feeling good, you're walking with somebody, versus you're walking outside alone. There's been rumors that there's this madman running around you know what I mean? Like your perspective about every sound, every movement out of the corner of your eye is going to be completely different. You're going to become hyper vigilant. You're going to be looking everywhere for threats. And this is a very common situation for patients where for various reasons they've begun to see their whatever their problem area is as threatening, as unsafe. And when that happens, the brain processes that stimuli differently in it. Instead of just kind of presenting it to us neutrally, it presents it to us in a way that, like, we're walking around where we think there's a murderer around the corner, and then we hear a noise right behind us. We're gonna react, right? And that's how the brain is responding to the stimuli from the GI system. And there's even a clinical name for it that's called visceral hypersensitivity. And that occurs fundamentally when the brain doesn't feel like an area is safe. So it's essentially amplifying the signals from that area and also sometimes distorting them. So you might get something like a full stomach being perceived as painful.
Right, but it is actually painful. I want to keep drilling it in over and
Yeah.
over that this is not just only your head, that experienced pain is real pain. And I believe from Dr. Bain Vogel, she also talks about how they've done studies to show that different people experience gut sensation through their nervous, enteric nervous system differently.
Yeah.
Correct?
It's interesting because this concept, I think people get lost. Real pain, fake pain, all pain is in the brain. If we didn't have a brain, we wouldn't have any pain, right? So all pain comes, like, the brain is there to decide if something is painful or not, and then how much importance to give it. And it's a complicated multi-stage process where the brain is sorting and sifting and categorizing all the stimuli that comes from our body at all time. And it just doesn't happen in the gut. It also happens in other parts of the body too. So you talked a little bit about about functional disorders. There's a relatively newer term out there called neuroplastic pain. The field is rife with all these different terms. Well, one of them I really like is neuroplastic pain. And it's the idea that the pain isn't generated because there's damage to the body. It isn't generated because there's damage to the nerves. The pain is generated in the brain. And remember, all pain is in the brain. So it's not fake pain, it's not any less real. It's just as real as structural pain, meaning I accidentally cut my arm. That's structural pain. Whereas somebody who's got visceral hypersensitivity and eats some food and their visceral hypersensitivity is centered in their stomach, their those sensations of fullness will go to their brain and then be processed in a way that they perceive it as painful. That pain is entirely real, no different than the pain of me cutting my arm.
Great. That's a great explanation, but I'm still stuck with, well, how do you know how much to work the patient up? Because you
Yeah.
can't tell just from looking at that patient whether there's something structural you might be missing.
Right, right. Now, and now this is outside of my area of expertise because I rely on pediatricians, I rely
Mhm.
on, pediatric gastroenterologists. I just have a vague understanding of that. And that's why myself and then my practice, GI psychology, we always need some level of workup, right? We don't want patients just coming directly to us, and that's been our philosophy since we started. We haven't advertised directly to patients or their parents. We've reached out to the medical professionals because we see our work as being done in partnership with them.
This is so, so important, and I'm glad you said that so clearly. And that's why I'm going to link to the Dr. Bain Vogel talk, because she provides the medical piece that we're not going to be discussing here. So I'm trying to say over and over the same basic thing, that we can say, A, the pain is real, and B, we're going to look for structural things, because you don't want to be in the situation where you're assuming it's functional disorders of gut-brain interaction, that there is no structural thing, but there was and you missed it. And so I think these things have to go on parallel tracks. The question is how much, and the attitude. If the attitude is, say, the parent is anxious, and no matter how many times you tell them we've done a reasonable workup,
Right.
right, and they're still anxious and want more done, that may be the tricky spot, how much to do, right? And also the attitude, which leads me, I really want to talk a little bit about the attitude of the parents and how that can affect this.
Well, I love, and is it Dr. Vogel that you're referencing?
Bain Vogel.
Vogel. I love what you're saying because, again, that's what I saw in my career. At first, I was the last stop, but as the understanding of the science has evolved, as people in the area learned to trust my work, and what I was seeing more is they were bringing up gut brain therapy in the first visit. They're saying, look, you've had this pain for X amount of time. We're going to do a reasonable workup. We're going to make sure it's none of the red flags. But the good news is it looks like it could be a disorder of gut-brain interaction. And if it is, that means it's very treatable. We've got just the person to send you to, right? Like, just putting that idea in at the beginning versus after you've exhausted all the testing makes a huge, huge difference.
It really does. And I want to get the message out to healthcare professionals as well, because I do think that there's a huge stigma of, I'm going to see this patient and I think it's functional and I'll just do the workup and then I'll send them out. And I think the message they may unintentionally be conveying is, this is not as real.
Right, right. Because they're saying, well, it isn't all these really serious things, so you're good. But the fact is, that patient is absolutely not good.
Right, right.
They are suffering just as much, maybe more than when they came in. They still need a lot of help. And by just saying, hey, you're good, they can feel really abandoned. And, there can be different reactions. There could be one reaction, okay, we just have to live with this. The reaction can be, no, we're going to find out what's really wrong, right? And we don't want them to do either, right? We just want them to get the treatment that's going to actually help them.
Right. I think it can be really helpful as long as you make sure you're validating that the pain is real and that it's really disabling and a problem, and you're going to try to help them feel better. But you're also going to look for structural things, and then you're not medical gaslighting, right? That, I think, unfortunately, I see this a lot with the parents, where they are so afraid that we're not taking it seriously.
Right, right. And I think there's an art to that, right? The providers, I think, who have the best, essentially like patient skills, they're able to form those good relationships, build trust. They tend to be the ones who aren't just like, okay, we do these tests, we did the test, you're clear, go on your merry way, versus, the ones who are, validating, helping them know that they understand, that there's hope. I really encourage providers to frame this as good news, because think about the other things they might have, right? It could be inflammatory bowel disease. It could be, different kinds of cancer. Like, the alternatives are not great. And the fact that they don't have those things, A, is good. And then B, the fact that based on 40 years of research, these disorders of gut-brain interaction are very treatable, to me, that's great news. And I think that should be conveyed to the patient in some way to build that hope and motivation to go forward and get help.
That's really, really true, because the bottom line is everybody wants to feel better. The child wants to feel better. The parent wants the child to feel better. And you can speed up that process by not first waiting to send them to somebody like you. We're going to get to more of what you do in just a few minutes. But I think that that's really important. And I think one of the problems is the interpretation that this must be psychological. And so I
Mm,
do want to talk about the connection to psychological and the resistance to that too, by the way.
yeah. And I think that's what makes this tricky, because I think just people in general, we don't do well with subtlety. We want something to be either this or this. And the problem with and I'm going to call them DGBIs,
Mhm.
because it's just shorter. The problem with DGBIs is, just like we were talking about earlier, everything's connected. We're not this isolated entity. Our brain is affecting our gut, but that also means that all the different things going on in our brain is also affecting our gut. So I can give you an example. Let's say there's a kid who develops what's called post-infectious IBS, right? So you're, of course, very familiar with it. They get some kind of infection, an infection you can measure, you can see. They get over the infection, however they get over it, and then the problems continue. So the pain or the discomfort or the vomiting might continue. With IBS, it would be more likely pain and or constipation and diarrhea. So there's symptoms that continue. And so now what has been established is this connection between the brain and the gut, where this pattern of pain and altered bowel function has been established, and then it's being maintained by this dysfunctional interaction between the brain and the gut. So now you've got this pattern in the brain that's established, but guess what? It's not in isolation. So what does that mean? That means if the kid is extra stressed because of a test, it's going to go from the brain to the gut and the symptoms are going to get worse. Or if the kid is anxious about, learning to drive or whatever, like they're going to see more symptoms. And people can confuse that with, oh, this is all just anxiety disorder, or this is all stress. The problem is it's not just all stress. It's not just an anxiety disorder, but stress and anxiety affect the brain. And this is an open system that's kind of feeding back on itself. So you're going to see effects from stress, from anxiety, from mental health issues. And so that level of subtlety, I think, confuses people. They want like one or the other. Is
Right.
is it mental health? Is it caused by anxiety? Yes, no. Like it's a variable, but it's not caused by it. And it's more than anxiety. It's more than stress, right?
I'm guessing that you can have an anxiety disorder and have these, but also have these disorders without having an anxiety
Well
disorder.
said. Well said. Exactly. Exactly. More
And
people with anxiety have these disorders,
right.
but plenty of people who don't have anxiety disorders have these disorders of gut brain interaction.
I think that's really important to stress, because I think that, again, the physician or other healthcare professional are more likely to say, okay, I've ruled out the medical stuff, go to psychiatry, go to psychology.
Right.
This is an anxiety issue. And I think that the resistance
Yeah.
is rational, because sometimes it is, but it's not all that it is, and
Yeah.
sometimes it isn't.
And I've seen very, very frequently, especially when there weren't resources, like myself or the bigger organization available, what doctors would do is, they didn't have very many options. So they'd see the patient and they say, okay, go see a therapist in your community. And that's fine. That's not, well, it's not fine, really, because what would often happen is inadvertently the message gets sent, hey, this is because you have a mental health condition. This is because you have anxiety. And that well-intentioned therapist in the community, they don't know the specific techniques, the methods used to train to treat a gut brain disorder. They're just going to do what they know, which is treat anxiety, treat depression, and that might help a little, but it's really not going to help the core problem.
Very well said. And I think that that's something that we have to get into our heads, that anxiety is a problem that can be treated as anxiety, but gut brain interactions are not going to be solved by treating the anxiety alone.
Yeah, exactly.
And that's a great segue is, well, how do you treat these?
Well, there's two modalities of treatment that are well established, well researched. Like I mentioned before, 40 years of research. The one is cognitive behavioral therapy. And I say that, and every time I need to make the caveat, because this is where people get confused. Well-intentioned providers get confused because when they look at the research, they see CBT, cognitive behavioral therapy, and they're like, oh, we've got plenty of people out there in the community who can give this patient CBT. The problem is there are different protocols, different specialties within CBT. And what you're sending them to most likely is someone who knows kind of generic bread and butter CBT, and they don't know how to translate that into working with something like IBS because there's specific GI focused protocols for treating DGBIs. So, again, a lot of patients will come to me after seeing other providers and say, oh, you're going to do CBT. Well, that doesn't help. That doesn't work for me. And I say, okay, well, it's likely that you weren't given the type of CBT that you needed. So CBT is one, GI focused CBT, and then the other is clinical hypnosis. And clinical hypnosis is another one where a lot of explanation is needed because there's a tremendous amount of misunderstanding.
Talk more about that, please. I'm interested.
Oh, yeah, absolutely.
Go for it.
So I think the main question to answer. So again, the same thing I said about CBT applies to clinical hypnosis. There's tons of good research showing it works, it works, it works. But what the heck is it? Right. So, and you'll have heard this in my other podcasts, right? And I don't think I can ever say this enough. Take everything you know about clinical hypnosis, and it's probably going to fit into the category of entertainment hypnosis. Entertainment hypnosis is fun. It's a great plot twist in a movie or a show. It makes for a good stage show. It's like magic and witchcraft and weird things are happening, mind control. But that's entertainment hypnosis. So if we say, okay, then what is clinical hypnosis? Clinical hypnosis is probably one of the most studied techniques in all of psychology. Anyone wants to just check it out, they're listening right now, go onto your browser, type in PubMed. PubMed will take you to the national database for basically scholarly publications. And then just type hypnosis. You're going to get thousands of studies that have been done looking at this technique. It's been studied for a very long time. It's well understood. And all it is that as a human, we all go in and out of states of consciousness. One of those states of consciousness is called trance. Trance is occurring all the time throughout our days, even more so in kids than adults. They're zoning out, they're losing themselves in their games, in their play, in their imagination. When we drive somewhere we've been a lot of times, we go into trance. If we're watching a movie, if we're watching a game, we're really into it. Trance is happening all the time. All we're doing in hypnosis is we're teaching someone how to go into that state deliberately instead of accidentally. And the reason we care about trance is because in trance, it turns out we have more access to that mind-body connection. We're more internally focused, and through the power of suggestion and imagination, we're able to influence that mind-body connection in ways that we aren't able to in our normal states of consciousness. As an example, we talked earlier about visceral hypersensitivity. In trance, with someone who's got good hypnotic talent, we can literally turn down that visceral hypersensitivity in the moment. What does that
Whoa.
mean? That means that many, many, many times I've had patients come into a session 7 out of 10 pain, 8 out of 10 pain. 15 minutes later, they're at a 3, a 2, a 1, a 0 level of pain. It's not magic. It's not witchcraft. It's just utilizing the brain gut connection, understanding how hypnosis works, how the brain works. And people are capable of more than they realize.
Once you do this hypnosis, is it something they can do on their own later?
Yeah. So a part of that process, first, it's kind of like if you're learning a sport. You have your coach show you what to do, then you get feedback as you practice it with the coach. Eventually you get confident enough that you can do it in the game without the coach saying anything.
Wow.
Yeah. And so
Oh,
we
wow.
specifically teach self-hypnosis. Why? Because we have to. Because often the problem isn't happening when they're in the office with us. It's happening at school, it's happening in the morning, it's happening at home. So we need to teach them the techniques that they can use when they're not with us.
That is absolutely amazing. I'm going to get a little technical here. I'm guessing that that is what we call a bottom-up approach as opposed to CBT, which is top-down. Am I correct there?
Yeah, if you're thinking of the brain as like kind of the bottom parts of the brain, the limbic system, the emotional
Hmm.
parts of the brain, and then the top is like the cortex, the higher functioning. Absolutely. So you could consider hypnosis an experiential therapy. We're getting the emotions involved, we're getting feelings into it. Whereas CBT is more thoughtful, it's more intellectual, it's more logical.
That's a great explanation. I want to go back to the GI CBT because you mentioned that it's different from regular CBT, but I
Yeah.
want you to get a little more into depth on how it is different because I think this is such an important understanding.
Yeah. So first off, the practitioner needs to have an understanding, and this is a larger topic, right? So I have to be a little vague, but like the practitioner has to have a good model for how hypervigilance, catastrophizing, visceral hypersensitivity all are working, and the gut brain connection are all working together to create these self-reinforcing cycles. They have to understand the common cognitive distortions that these patients have. They have to understand how to look for the normal types of avoidance behavior that these patients exhibit, because avoidance is one of the this is a kind of a different topic, but avoidance is what feeds anxiety. So you have to find that avoidance and you have to slowly help the patient face it. And with these patients, there's certain particular types of avoidance they should look for. There's avoidance of places and activities, there's avoidance of foods, and there's even avoidance of their own body sensations, where they've developed fear of those body sensations. And we do something called interoceptive exposures, where we're teaching people to feel safe with their body feelings.
That's really incredible, and I can see how that could be so important. Do you train other clinical people to do this? Because I don't think there's enough of you out there.
Well, you kind of got to what was my frustration as well. So, I've been in private practice in the Northern Virginia area for 14 years. And they were very well. When you take all the different key parts, there was literally no one on an outpatient basis who could do this work. So what do I mean? I mean, who could work with kids and adolescents, who was trained in hypnosis, trained in GI CBT, and that were familiar with gut brain issues. So you have to have these four things, and there was literally nobody who helped put them all together. And so about 5 years ago, just out of frustration, like I was full, I didn't have anybody to refer to. And as you know, there's thousands of kids like with these problems. So myself and another psychologist, we created GI Psychology. And the mission, and we're very mission focused. And our mission was we wanted to create access to this specialized gut brain therapy, these gut brain therapies. We wanted to help patients with these GI disorders. And we wanted to do that in two ways. One, by training more clinicians, and two, by educating medical professionals like yourself and hopefully the people who are listening to this podcast. And so I've been in charge of, training those clinicians. And over the years, we've developed something I'm really proud of, this really extensive GI Psych University that that can takes a therapist with maybe some health psych experience, but no GI experience, and then in a structured, supervised way, it's very intensive, over about 6 to 9 months, turn them into a high level, competent GI psychologist.
Is phenomenal. And we're going to link to your website, of course. So I also want to talk about a couple of things. First, I just want to underscore, I feel like I have to keep saying this over and over, that the difference between GI, CBT, and hypnosis and regular therapy is you're focusing on helping with the pain, not with the potential underlying or coexisting psychiatric or psychological issues. This is very basic, but I'm presuming that anybody who is a GI psychologist also deals with those other things, that this is a tool in their toolbox, but not their only tool.
Absolutely, yeah. We also treat comorbid conditions. So
Good.
it's kind of like if they've already got a therapist, that's awesome. We'll go in, we'll do very targeted work, we'll work on the GI condition, and the other therapist can keep doing their job. But if the patient doesn't have another therapist, often what ends up happening is you treat their GI disorder, and then they freaking love you, and they're like, yes, and there's tremendous therapeutic momentum. And what that means is then you can treat their social anxiety or their history of trauma or their depression or whatever it is you've got. It's so much easier to treat it after you've already helped them with this other problem.
Right.
Yeah.
Right. And the Dr. Bainvogel works at a DGBI clinic, and it is one of those comprehensive multidisciplinary clinics that I wish we had
Nice.
for every patient.
Yeah.
It's not a thing in most places.
Right. And that's kind of what we tried to do, in the sense of, because GI psychology is telehealth in all 50 states. So the idea is that for all those clinics that aren't lucky enough to have that great wraparound treatment, which we know is what we should all be aiming for, right? What we've been able to do is slot in to these different clinics and be their GI psychology resource.
Wow.
So, for example, I told you that we haven't advertised to patients. We've tried to create partnerships with organizations. So one of the first partnerships that we had was with PSV, so Pediatric, I think, Associates of Virginia's. I always get their name wrong, but basically they're all the pediatric gastroenterologists in Northern Virginia. Then it was with Georgetown in their GI clinic, and then UCLA, and then Mayo Clinic, and then Cleveland Clinic, and then we formed these bigger partnerships with the Crohn's and Colitis Foundation for all those patients with IBD. And and also the American College of Gastroenterology. So the big overarching organization that works with all the gastroenterologists. So our goal has always been to be that resource that can slot in and be that GI psychology support wherever we are in the country.
It's really amazing. And you said something very interesting. You mentioned IBD. So again, back to the real versus not real.
Yeah. Yeah.
False dichotomy here,
Yeah.
right? That people with IBD have pain and that pain can be helped too. It's not a matter of this is only for the functional pain.
Exactly.
Right?
So IBD is an interesting one because there's a tremendous need for GI psychology with patients with IBD on numerous levels. So as an example, patients with IBD have an increased risk of depression and anxiety. And just at a baseline, there's very few clinicians who even kind of know what IBD is. Frequently, they're mistaking it for IBS, right? And so we're talking about Crohn's and colitis. So we've got increased depression and anxiety. We've also got increased rates of medical trauma. There's different surgeries. They go through a tremendous amount. When there's a flare, they're often in the emergency room being treated when their symptoms are flaring. And then there's also an increased risk of DGBIs because of what they go through with their GI system. They're more likely to develop a disorder of gut-brain interaction on top of all these physical structural symptoms that they're having. So even when they manage to get their immune system under control, they're still having symptoms. And why are they having symptoms? Because they also have, on top of the IBD, they're having disorders of gut-brain interaction as well.
I mean, in my mind, I'm not even thinking about having to call it a DGBI. I'm saying you have pain,
Right.
and learning how to deal with it and help you with that pain is an important component in your treatment.
Yeah. And that's really something we do a lot of work with, really wherever the pain is coming from, whether it's structural or if it's nervous system based or if it's nerve based. There are many different techniques and methods for helping people reduce and manage their pain better.
That's really very, very helpful. But I want to go back a little bit, something I'm trying to get you to talk about, and it's hard to talk about, but I'm going to push anyway. And that is the role of the parents. And the reason it sounds like if we say the parents can make it worse, then we're blaming the parents, and we are not going to do that here.
Yeah.
But we need to talk about the role of the parents. Do you, by the way, work with families as a whole or just with the individual?
I would say that if I'm working with kids, especially the younger the kid, it's rare that I wouldn't be meeting with the parents also. And this is a distinction that's kind of subtle, which is the difference between family. So there's let's say family therapy, which is a thing. And then, parent training. You might work with a parent just to help them on their parenting skills. Or you're working with the patient and then you're bringing in the parent to help with that patient's treatment. So there's a lot of kind of subtleties and different things along that continuum, but especially the younger the kid, the more I think it's a general rule, the more you need to be working also with the parents.
Why? I'm pushing you.
Yeah.
I'm really pushing hard because this is important. As a pediatrician, what I see all the time is parents are the worst pain in the world is experiencing your child's pain.
Right.
Right. So the parents' experience of it and how they can regulate with their child, to use that psychological term of co-regulation, is so important. And I want you to talk more about that,
So
please.
I'll give you an example. There's some research looking at parenting style in terms of patients with DGBIs. And they found that the best outcomes were for parents that did not have an empathetic style. And this is, again, not blaming the parents, because there's plenty of situations where an empathetic style is helpful, is useful, it's good. But when patients have a DGBI, it's not. In fact, it can make things worse. versus parents that have kind of a more matter of fact style. Like, yeah, I'm sorry to hear your stomach's hurting today, and we still need to go to school. So, let's go pick out some clothes and get ready, right? It's versus like, oh my gosh, my poor baby. And, like that actually tends to make it worse. And so what I say to parents often is, you know, what you've been doing has been good, but now you have a child that has different needs. So we need to learn different ways to interact and different ways to work with that child. Just like any good parent, if their child suddenly has different needs, you're going to adapt to what that child needs. And that's what we're doing here. You have to sometimes learn a different way of parenting when your child has needs that are different than the average kid.
It's really a great explanation, but I want to make it clear that we're not talking about dismissing your child's pain. I think there's studies on
Right.
that as well, that those parents aren't helping either when they're saying, "Oh, snap out of it." Again, it's a problem if the doctor says, "Oh, everything's normal, it must all be in their head. Get
Yeah.
them to school," because they're just trying to avoid school, which is a whole separate podcast.
Yeah. School avoidance is something that I worked with a lot, throughout the years because these kinds of problems often lead to school avoidance. It's really natural, because what happens is your kid's stomach starts hurting chronically, so they're missing a lot of school, but the problem is the more school they miss, the more they develop anxiety about school. So then you develop that as a secondary problem. And then if they miss even more school, they start developing social problems. The kids, you aren't seeing the kids very much, the kid isn't socializing enough. And so you start developing all these secondary problems. And so it's really, really imperative to get them back to school if they're not there, or to prevent them from missing a lot of school if they're just developing one of these problems.
Right. And that's why, again, the GI psychology therapies are so important, because you can't just say, get to school. You have to go to school.
So
You have to have them have tools to cope with the pain.
absolutely, you have to give them tools to cope with the pain, the fears, the stress,
Right.
the anxiety, the unique situation that they find themselves in. We've got the tools because we've seen it over and over and over again. But just a parent saying, this is all in your head, get your butt to school, it's going to end badly. Right.
Right, right,
Yeah.
right. You need that middle ground. You need a certain amount of empathy, but a matter of fact, you need to go to school, and this is how we're going to help you cope. And I think it's important to underscore that avoidance underlies making things worse here,
Yeah,
including
absolutely.
avoiding going to school.
And in the world of psychology, we have this term called scaffolding. Right. It's the
Mhm.
idea of figuring out where the kid is and then giving just enough support to get them to the next level, and then give them just enough support to get them to that next level. And it's not just like, oh, go from A to Z just like that. It's more like, okay, knowing exactly what they need and how much they need and how to give that to them so they can kind of move up that ladder.
That's also a really good explanation. So I really want to thank you so much for your time today. I just want to give you a chance to say how we can find you, how we can access your programs.
Yeah. Our mission is to get the word out there to the doctors, the nurses that are seeing these patients. And we can be reached at gipsychology.com. And there, what you'll find is you can like look at all the different research, you can watch videos, you can learn all about this stuff. And then if this is something that could be helpful, we've got a free phone consultation, and you can talk to someone who's trained to answer all your questions, answer any questions about the cost, the admin, all that stuff. And if it's something for you, you can sign up and get started. If not, that's fine too. But the key part is just building just more and more awareness over time so that people do not have to go years and years suffering needlessly when there are good treatments out there.
This is amazing, and I hope more and more professionals take your course so that it becomes more widely available, because I think it's so incredibly needed.
Thank you. I appreciate it. And it was really great talking with you.
You too. Thank you so much. Thank you for listening to Kids Matter. Raising healthy, happy children takes a village, and I'm grateful you're part of ours. If today's conversation resonated with you, please share this episode with another parent, grandparent, teacher, or anyone who cares about kids. Together, we can build the supportive community our children deserve. I'd love to hear from you. Share your thoughts, questions, or suggestions for future topics at kidsmatterpodcast@gmail.com with no exclamation point. Your voice truly matters. Until next time, keep advocating for the children in your life, because kids really do matter. They are our future. I'm Dr. Elisa Minkin, and this has been Kids Matter. Please note that while I am a pediatrician, I am not your child's pediatrician. This podcast is for informational purposes only and does not constitute medical advice. For any medical concerns or decisions, please reach out to your child's healthcare professional.